All right, can people hear me now? Yes, okay, perfect. Let me go ahead and just go over the logistics. Sorry about that. For this session, we did a quick poll. I just want to say we're really excited to have everybody joining us here today. We have a really diverse audience, which is fantastic. That's really part of the goal of bringing everybody together. And we have an amazing lineup of speakers for you. I just wanted to take a second and introduce myself. My name is Dr. Elizabeth Baca, and I'm the Senior Health Advisor in the Governor's Office of Planning and Research. And I think we have a great afternoon for you today. A couple of logistics. The session is being recorded. We want to make sure that we're able to share this with folks that weren't able to join today. We have muted lines, as you just saw. Make sure you're unmuted and muted when you need to be. Since we have a large number of participants, we're going to have all of the attendees muted, but we encourage getting questions, and there's a question box on the right lower hand part of your screen, which you can type in some questions. If you have technical problems, if it drops, or if there's anything, they always say technical stuff works almost 100%, 90% of the time. Feel free to call the number for GoToWebinar, which is 855-352-9002. A little bit of background for the series. I think one of the things is a lot of folks have been, there's a ton of work going on around building healthy communities, and particularly within California. The governor issued an executive order back in 2012 and brought together an amazing expert panel to think about the fact that we have rising chronic disease. We're going to hear a lot about that actually from Dr. Jackson. But the panel really was thinking in a broad perspective, how do we start to think about providing better health and better care at lower costs? And I think that the group really had a lot of foresight in thinking about how health services are really important, but it also goes beyond that in healthy communities, and it was really important to set the framework. I think one of the things that can be really challenging with creating healthy communities is it does take a lot of sectors coming together. It really means partnering with folks who you might not have partnered with previously, and being open to learning and really expanding in different ways. Some of the work we've been doing here within OPR, and we've gotten a couple questions on there asking about the general plan guidelines. We will, a very exciting update is the guidelines are going for internal review right now, and after that final piece with the different agencies will be going out for public review shortly, and so we're really looking forward to that. One of the components of that is we did a lot of work doing outreach across the state of California to really talk to a lot of the people who are doing this work on the ground and to learn what were some of the best practices, what were some of the challenges, what were some of the lessons learned, and how to move this work forward. And what this series actually came about based on all of that outreach, and also was inspiration. OPR hosts something called the Local Government Roundtable, which really brings together folks from local governments across the state to think about some of the things and issues they're facing, and is an excellent forum to really get information out. And the state, the Department of Public Health actually put together the State Wellness Plan, which is really building off the framework established in the Let's Get Healthy California Task Force. And I was participating in a conference for the Wellness Plan and actually took a pledge to start to bring folks together. I think it's this work, especially with some of the work going on at the state level with the Health and All Policies group, which you'll hear a little bit about from Heather today, just really encompasses how there's a lot of leadership going on in this place. And with the series, we really wanted to focus on local innovation. So just to give you a sense, today is our very first webinar series. We're really excited for the inaugural webinar, but we will be over the course of the next year hosting series of a ton of different topics, really integrating things from process to data to implementation to funding across a whole host of different topics. So it'll be very, very exciting. And today wouldn't be possible without an amazing leadership group who really helped bring this together. I wish I could say something about all of the folks up there. They've really been tremendous in guiding how to design the series and who we should invite for speakers and some of the topics. And so this today wouldn't be possible without them. The other groups that I'd like to thank are the sponsors. So we actually have the California chapter of the American Planning Association sponsoring us today, which is fantastic. We have the Health Officers Association of California as well sponsoring us today. And just to make sure for disclosures, none of the speakers or Planning Leadership Committee have anything to disclose. There is going to be a survey at the end of the webinar, and then if you can't complete it today, there's a survey that will go out with the email, the follow-up email you'll get tomorrow. We would encourage everyone to fill out the survey because we really would love feedback, and we want to make sure that this is meeting your educational and practicing needs. However, if you're applying for credit either for continuing medical education or for the American Planning Association for California for AICP, the survey that's going to go out does need to be completed, and we would request that you do that by 6:15 so we can make sure we get that to the appropriate entities in time. The other piece is that for planners, you're going to, in addition to the survey for this, we'll actually be sending you an email, separate email from APA with additional information so that you can complete your credits. It should take about 1 month. So one of the other pieces is, as we were talking about a lot of this work, one of the big things is having the opportunity to connect with others who are doing similar work. It's been really fun over the last year to learn a lot about the projects going on in different cities and counties across California and also beyond, so in other states. And one of the things is that we haven't been able to share that as much. And so, we will be looking, webinars are great first step to starting to do some of the education, but a lot of this work happens through connections. And so anyone who's registered for today will actually be sending out a LinkedIn invitation as a place to be able to share funding opportunities and resources and conferences. So we'll be sending that shortly. And then the last is that we have a host of learning objectives today. And I think today is really the first one, the big picture, how all of these things integrate. The role of the built environment in planning and how that can impact health, really thinking about some of the demographics and the broader planning perspective and partnerships. So it's really a really great high-level overview of all of the challenges to health from the community side, and then some of the things we can do to start to make a change. And I couldn't be more pleased to introduce our two speakers today. We really have two fantastic folks who have just been amazing leaders in healthy planning. I actually am also a pediatrician and remember reading Dick Jackson's book about, I guess it was about 10 years ago, on the built environment. So Dr. Jackson is a professor and a former chair of the Environmental Health Services at the Fielding School of Public Health at UCLA. He's a pediatrician, and he served in many leadership roles, both within the California Department of Public Health, as well as serving for 9 years as the director for the Center for Disease Control and National Center of Environmental Health in Atlanta. He's published quite a bit. As you can see, some of those are some of his recent series. I actually used to use them for teaching purposes, and so it's really fantastic to have him. And we also have Ms. Heather Wooten, who is the Vice President of Programs at ChangeLab Solutions and also a colleague that has been really fantastic to work with over the last couple of years. ChangeLab Solutions is an organization that does a lot of leadership around healthy planning, researching best practices, and really developing policy tools to work with communities so that they can connect land use, community development, and health. She also has been the author of several publications, a couple of them specifically related to healthy general plans, and I couldn't be more excited to have both of them here today. On that, I'm actually going to let Dick Jackson take it away, so I'm going to be handing over the controls to you, Dick. All right.
Thank you very much. Let me go up. I just want to make sure you can hear me.
You are perfect. We can hear you well.
I'm going to argue that health needs planning, planning needs health, environment needs health, and health needs environment. And we've been isolated from each other for far too long. Why does healthy planning matter? The trajectory for Americans' health is going in the wrong direction. In the last 25 years, we've gained about 25 pounds. These pictures of the United States, based upon telephone interviews of 200,000 people a year done by CDC, show the unbelievable change in the rate of obesity in our population. At this point, a third of our adults are obese, another third are overweight, and about a third are of what we used to consider healthy, normal weight. So we're looking at an avalanche of obesity in our population. We all know that obesity is not good for us, but it raises the risk of joint disease, of having a baby with a birth defect. WHO recently came out saying that the cancer risks from obesity may in fact exceed the cancer risks from nicotine in many of the developed countries, or at least from cigarettes. So these are very big changes. But one of the diseases we worry about very much in terms of increasing body mass is diabetes. For men, you can see the increase in our risks of developing this disease, and if my body mass index were 35, I'd have 42 times the risk if compared to when I was thin. But for a woman, it's 93 times at the highest level. And this has caused a huge change in the rates of diabetes in the United States. So we've shifted from infectious diseases in the past to chronic diseases as the epidemic that is crowding in on the American people. The graph for diabetes in the United States, 1994, 2000, 2010, is just as dramatic. And so now you walk down the street in Texas and one adult in 9 has a disease that will cost them their eyes, their kidneys, and their feet, and eventually their hearts and their lives. It's a very expensive disease with complications. My video series, I remember interviewing a man, and we show him who at one point said diabetes is nothing to fool around with, as he looked quite healthy, middle-aged man, but he was facing a foot amputation at the time. 2% of the entire GDP of the United States is going to this one chronic disease in our population. And as a pediatrician, I remember when I was in San Francisco in training, I'd go to the Children's Diabetes Clinic. I never saw a child with adult onset diabetes. That's what we called it back then. And now half the children in the juvenile diabetes clinic have quote unquote adult onset diabetes, and their health trajectory is actually worse than the kids with insulin dependent type 1 diabetes. CDC, NIH, and others funded a large study looking at what was the best way to prevent type 2 diabetes, and they had 3 different drugs, and they compared one other intervention arm, which was walking, and they had people walk for 6 months, or 30 minutes a day, 5 times a week for 6 months. People lost weight, and they reduced their risk of diabetes by almost 60%. No drug works as well as walking. And certainly no drug is cheaper and has fewer side effects. Walking has the fewest side effects of any of the drugs we'd be looking at or ways we would be looking at to treat diabetes. So we physicians have been telling people, look, you've got to walk, you've got to exercise, you really need to build physical activity back into your lives. It's an independent benefit. Simply besides preventing diabetes, it prevents a whole series of other diseases, reduces depression, does a bunch of other benefits. And this study that came out about a year or so ago was just shocking to me because I thought we were making real progress with physical activity. There's a study that CDC does of about 5,000 people per year, a very robust sample of the American people, balanced ethnically, geographically, age, etc. And they compared people's health in the last couple of years, adults' health between ages 46 and 64, the prime earning years of life, compared their health with the health of people 20 or so years before. 20 or so years before, only 17% of the U.S. population had no regular physical activity. Now we're at 52%. So on top of the obesity epidemic, the diabetes epidemic, we have a profound epidemic of no physical activity in the U.S. population, to the degree that 2 out of every 7 volunteers for the United States military, young people, cannot get in because of obesity and lack of physical fitness. So I'm going to assert that the only way we're going to get people to walk more is to begin to create environments that induce people to do it. The other big fear, it's not simply the Pentagon fearing recruits, it is the crushing costs of chronic diseases. We've seen a dramatic increase in the costs of medical care in the United States to the point that we're about 17-18% of the U.S. population, 17-18% of the general GDP of the United States going to medical care. But this chart I find completely shocking. It's a worldwide scan of life expectancy and what various countries spend for health care. And yet we know that about the 30 of the years of increased lifespan during the 20th century, of that, about 5 years came from medical care, and the other 25 years came from the changes in the physical environment that we've made. So around the world, you can see that roughly life expectancy does track along with health spending to a degree, but look which country spends the most, on about twice as much on average per person as most of the rest of the developed countries around the world. And look at our lifespan at about 76 compared to the other countries. If we were getting our bang for our buck, we'd be up around 84 years instead of about 76 years. So we're in danger economically, medically, and I think in some ways socially. And I will assert, and I've been in many meetings with community health and medical care and all the rest, but in many ways, environment is a powerful determinant of health, and possibly even the most powerful determinant. And those of you on the phone who help design and plan cities, towns, buildings, transportation systems, parks, etc., are health leaders. And that's the big message I want to give across. And you need to embrace your health mission along the way. I lived in Atlanta for about 10 years, and half the parks in Atlanta you could not get into unless you were driving a car, because too often we don't think about people's needs. Here's a profound example. I think it came out of USC. This was published about 2 months ago, and what they did was examine the lung functions of children. Lung function is really important. The higher the lung function of a young child, the longer they ultimately live. It's a powerful predictor of how long you live. In 1994, 8% of the children in Los Angeles had poor or low lung function. In the last year or two, it's down to under 4%, and it correlates quite strongly with environmental controls. Environmental protection really does work in terms of health, and we've seen it over and over again. But, you know, a lot of people don't like environment, and Governor Schwarzenegger signed the Greenhouse Gas Reduction Act. It was called AB 32, and it was seeking to reduce carbon dioxide and other greenhouse gas pollution of the planet. And two Texas oil companies, Tesoro and another one, sponsored a proposition, which they named the opposite of 32, which was Proposition 23, to kill the greenhouse gas reduction law. It really brought a lot of people to great concern, but the companies were advertising aggressively to particularly minority populations, Latino populations, saying, look, all these environmental protections, the air pollution protections in California, they're bad for your job. They're endangering your well-being. They're endangering your income. And this campaign was really worrisome in terms of would it pass and undermine any of the environmental protections we were trying to put in place. And we're on the phone now with the health officers, and I want to thank Bruce Palmer and all the county health officers around the state, but also Kaiser Permanente Catholic Healthcare, and many of the other groups that stepped up and said no on Prop 23. And what was amazing to me about that was when the election finally happened, the election in the United States in 2010 that received more votes than any other contest in the United States was no on 23. It actually received more votes than Governor Brown, Governor Cuomo, and our senators, because poor people understand the health of the environment is linked profoundly to the health of their children. We've built communities foolishly, and we never think about people first. We think about cars, we think about return on investment, we think about convenience, and here's two homes that are in a typical subdivision we build in the United States. And imagine you lived in one of these two homes and you wanted to get together for a barbecue for the 4th of July with the person on the other side of the fence. You really didn't want to throw the baby over the fence, so you decide you're going to drive to the 4th of July party. And so you go to Google to decide how to get to your new neighbor's house, and you have to drive 7 miles, drive 17 minutes to get there. I put this in as a joke slide, but in many ways it epitomizes it. You've seen it over and over again, that we build for the convenience of cars. And the Department of Transportation's, particularly Caltrans, is seeing their role very differently. And I want to thank Governor Brown and his leadership and the Office of Planning and Research for that leadership. We're beginning to say we've got to build for people's well-being and health first. We've done a wonderful job through the American Institute of Architects and sustainability groups and environmental advocacy groups to build buildings that are green, that are sustainable, that meet LEED certification, but they also need to be healthy. They need to, for example, include stairs, include ways that we can have physical activity. Of course, it's going to welcome people that need to use elevators, but young, healthy people have no business standing on an elevator. So health needs environment. Environment needs health, and I could think of many examples, and I already just showed the AB 32 one, but one of the things we're going to have to think about very deeply in California with the water shortages we're facing and what we're doing to future generations by the depletion of water and resources and damage of air quality is that we're going to have to move from a strictly regulatory and engineering view of what's happening in our environment to one that is also about health and moral obligation to the people in the future. And one big example I'm going to give is that I have read probably in my life about 100 environmental impact reports. If 997 pages of it dealt with air standards and water standards and noise and everything else, only 2 to 3 pages deal with any kind of health that I would think about that I've just talked about, which is how do we create healthier communities and what's the overall well-being of people. And this issue of environment needing health is captured in the National Academy of Sciences report, Improving Health in the United States, that came out a couple years ago. And I'm going to call your attention to just 1 or 2 sentences in that big report. I really do recommend you call up the role of health impact assessment from the National Research Council, National Academy of Sciences. We need to integrate health impact assessment into environmental impact assessment. Quote, the appropriate assessment of direct, indirect, and cumulative health effects in environmental impact assessment under NEPA, the National Environmental Policy Act, is a matter of law and not discretion. So we have got to begin to shift environmental impact assessments in ways that much more effectively capture these impacts on health, impacts on our children, impacts on future populations. So we've made a good start. Many of the county health departments have a health person going to the planning meetings and sometimes to transportation and other meetings that's happening at the government level. But in my personal opinion, I think we're going to need explicit policies leading to much more effective codes, more powerful general plans, and enforceable laws. So with that, thank you very much for your attention.
That's great. Thank you, Dick. And we've had a couple of questions, but first I actually wanted to see, Heather, what your thoughts are on the presentation. I have a couple of questions, and also from the audience, if there are a couple of questions that we might be able to take before we move on to Heather's presentation.
Yeah, Elizabeth, I did have one quick question for Dr. Jackson. So, Dick, you and I have been talking about this issue, as Elizabeth alluded to, for more than 10 years. But, you know, it's been 10 years of a lot of change and awareness, I would say. And I'm wondering about what you think about how people are coming to this problem today and what resonates now about this work.
Thank you, Heather. One is a dozen years ago, a number of home builders, actually the Association of Home Builders, tried to get me fired from CDC because I suggested that how we were building America was bad for people's health. That's changed, and the Urban Land Institute, some of the biggest developers in the world, in the country, have now embraced a very strong let's build healthy communities. The head of the whole organization last year said out loud, we used to build around golf courses, now we need to build around health. Another example, and a later speaker and a person you thanked at the beginning was Sarah Hammerschmidt and Rachel McCleary at Urban Land Institute. They've got a wonderful toolkit and guidelines for this. So we've seen that. We've seen the American Institute of Architects go from not even being aware of the health issue, other than making sure buildings don't fall down on people, to actually embedding health into the decisions. We've seen a number of county general plans step up thanks to Change Lab's help and guidance on doing that. So I think there's been a real change, and there are now more than a dozen joint programs between urban planning and design as connecting over to public health around the country. And I would say I've seen a big change. For example, English language articles that dealt with built environment and health. When Howie Frumkin, Andy Danneberg, and I looked at this about a year ago, before 2003, there were only 60 articles in the world's literature. Now there are about 600 or 700, and none of us can keep up with the articles that are coming out in the scientific literature. So the scientific database that's arguing for designing walkable, healthy, low pollution, socially connected, healthy food communities has become extremely robust.
That's great, and I think, you know, as you mentioned, it's really this collaboration that's just been moving more and more towards really thinking about broader impacts, and it's been fantastic. I actually had a question come in more specifically on related to the use of BMI as a method. So you know, we talk about BMI, but you know, maybe somebody who's a bodybuilder who doesn't exercise could be the same height and the same weight, and so are there other alternatives? Is that an effective use? Should we be tracking that? Is that something that you look at maybe from a city or county perspective?
You know, I think BMI is, when you're looking at 200,000 people, you need some standardized way of doing it, and you can get height and weight on almost anybody. One of the problems with the telephone interview is people endlessly fib about their height and weight. They're usually shorter and heavier than they say on the phone. As you know, as a pediatrician, Elizabeth, we usually go by percentile rather than by in the various percentiles in the height and weight chart. I would argue that from a population standpoint, BMI is a very good way of seeing a shift in the population. I do think on an individual clinical basis, it really is up to the judgment of the clinician meeting with that person. Obviously, a linebacker on a football team is going to have a very large BMI, but probably is going to be extremely robust as well.
Great. And one more question is, you know, one of the things is, you mentioned the lung function study test, and that really, it's great. It shows that policy changes can really have an impact, but it takes a long time. What are thoughts on how to keep the momentum going?
You know, all of this is going to take a generation. The tobacco effort took, frankly, a generation. We still got plenty of work to do, but it's going to take a while. 20 years is a short time when you're trying to move 320 million people. And it took us 60, 70 years to build a landscape in the U.S. that is dispersed and penalizes people for being physically active. Around UCLA, for example, we're in a big battle to try and get bike routes put into a neighborhood that's got some of the best weather and bicycling weather in the United States, but a big pushback from a community that really likes to drive big cars and not pay attention to people on bicycles. So this is not a battle that's going to be won quickly, and it means that we're going to have to build research. We're going to have to develop a narrative of success, so the success stories are very, very important. And the continued generation of this data. And I am very impressed with the young people, for example, coming out of my institution, that they're very committed to this. It's not going to go away.
Great. And I think to your point just about bicycles, I mean, I've seen some really phenomenal work being, you know, and research coming out of Caltrans and Department of Transportation, both at the state and at the national level, so that's been really exciting. We have a couple more questions that are coming in, and definitely keep sending them. We're going to try and get to all of them, but just for time, I'm going to go ahead and I'm going to hand controls over to Heather, so we can hear how we start to solve a lot of these challenges. So Heather.
Okay, I should be up. Does this look
right?
Great.
You're up.
Thank you. Well, thanks for having me. My name is Heather Wooten, and I'm a Vice President of Programs at ChangeLab Solutions, where we create healthier communities for all through better law and policy. And as an urban planner, I've spent the last 10 years working at the intersection between planning and public health through our research, resource development, and trainings, and I'm just thrilled to be sharing the stage virtually today with both our OPR and Dr. Jackson. So I want to go back to something that Dr. Jackson talked about to sort of set the stage for my side of the conversation about healthy planning. And that is the fact that health is influenced by the interaction of many factors and not simply genetics or individual behavior or lifestyle choices or even access to healthcare. And it's now widely accepted that the environments in which people are born, live, learn, work, play, and age actually have the greatest impact on health outcomes across populations. Researchers and public health professionals refer to these environments as the social determinants of health. So that's a little bit of a wonky phrase, but the concept is really important. This understanding of the role of social determinants has led to a call for public policy that can actually shape social, economic, and physical environments in ways that are much more conducive to human health. However, this is the important part, policies targeted at the social determinants of health are typically developed and implemented by agencies other than health departments, and certainly by folks other than doctors and medical professionals, and that includes planning. So if we look at major contributors to health over people's lifetimes, whether that's access to economic opportunity or education or quality housing or safe neighborhoods, almost every single one of these are shaped by planning and planning policy. And at the same time, government agencies generally work in isolated silos. That's the business model we have pursued in government, resulting in disjointed efforts that prevent us from effectively tackling these major societal challenges like violence, poverty, climate change, and chronic disease, exactly the challenges just outlined by Dr. Jackson. So one approach that communities are using to try and better align our limited public resources to better health outcomes is a model that's often called health in all policies. The model goes by different names in different communities, and some have chosen to focus on equity, others on wellness, and yet others on sustainability. And actually, the name is less important than the underlying idea, which is to adopt a collaborative approach to improving the health of all people by incorporating health considerations routinely into decision-making across sectors and policy areas. And it's actually a new model of government. It's a much more networked, interconnected, and collaborative model than we've pursued for the last 100 years. And it's really about shifting process, not just adopting any one individual healthy policy, as beneficial as these one-off policies might be. So to implement health in all policies, local governments must adopt a new approach to decision-making, and it requires both collaboration and strategic action by the various agencies or departments whose policies and actions affect those social determinants of health. And of course, in addition, the same public agencies have to engage with residents, with community-based organizations, and with experts so that we can gather data and we can ensure that changes in decision-making are responsive to community needs. But the bottom line is you can't get interdisciplinary solutions unless people talk to each other. So I want to provide some examples of health in all policies in action, focusing on healthy planning in particular. And we have these 5 building blocks of a strong health in all policies approach: convening and collaboration, engagement and envisioning, making a plan, investing in change, and tracking progress. And I hope that both the framework and the examples I'm going to share will give you ideas that you can implement in your own work. So our first building block is convene and collaborate. And this is really all about creating internal relationships and establishing shared goals between public agencies. So in 2011, I wrote an article for Planning Magazine that was profiling some interesting healthy planning work that was happening in San Mateo County. And there, the planners and public health staff that I spoke with really highlighted the importance of this growing relationship between the public health and the planning department. So here are a couple of quotes from when I first spoke with them. Part of the growing relationship meant finding new ways to talk about health. So as F.T. Meyer said, we used to go and talk about immunization or H1N1. That was bird flu, for those of you who remember. Actually, I think that might have been swine flu. Dick can correct me. He knows better than I do. But we started talking about land use and health, or the connection between food access and health. And importantly, the public health department there actually used local data to help make those connections. They were creating maps and briefs that provided an overview of health data and environmental conditions, like access to healthy food outlets. At the same time, their county's long-range planner saw the benefits of this relationship firsthand, and he's noting, health departments are staffed with people who can be a great resource to the planning department. We can only solve these public health problems if we collaborate, and local governments can't do this on their own. The more we work together and with our community members on plan development and implementation, the more successful we'll be. So at San Mateo County, an interdepartmental working group grew out of some initial corridor planning that they were working on, and it actually continues to collaborate to this day. But it's not a unique model to San Mateo County. Communities up and down California have adopted a similar approach, including Riverside County, and I just wanted to point out at least one other example for you all. So the Riverside County Health Coalition has grown beyond just public agency partners to include both public and private sector, including a variety of county agencies, their school district and colleges, local and regional foundations, as well as community businesses, cities, health clinics, medical organizations, and healthcare plans. And whether it's an internal agency working group or something that pulls in a wider group of people, these ongoing shared tables are great places to learn about opportunities and challenges, to understand each other's constraints, and to leverage each other's strengths and resources. So that brings me to building block number 2, which is engage and envision. So community engagement is often a core part of local plan making, but bringing a health lens to the conversation can reach new audiences in new ways. Just one example, here in Southgate, a built-out suburban city that was about 100,000 people in the Los Angeles region, resident engagement played a major role in shaping the health policies in their general plan. So their planning team included consultants, city staff, the Los Angeles County Health Department, and a community-based organization who was tasked with designing a more inclusive engagement process to reach the city's majority Latino population, many of whom are Spanish speakers, and including people who only speak Spanish as their single language. So they held meetings at this centrally located community center and provided simultaneous translation, food, and childcare to make sure they were reaching those residents. And by leading with a health message, the workshops brought together hundreds of residents who shared their priorities, like improving a local farmers market, attracting a full-service quality grocery store, and limiting fast food restaurants near schools. When Southgate's general plan was adopted, community health priorities were absolutely embedded in their policies. And in Kern County, just southeast of Bakersfield, the city of Arvin also used health to guide community engagement in their general plan update. So to illustrate their vision, they got together, a city planner and a staff person from the public health department got together to lead a series of workshops at schools to ask young people how they would envision a healthier future for their town. And those young people drew pictures just like this one, depicting some of the city's current health challenges. You know, they're in the Central Valley and they're dealing with a lot of air pollution and traffic, alongside a picture for a brighter, greener, and healthier future. And here you can see new green space, renewable energy, and of course, a happy sun. Those drawings and the aspirations behind them were actually the centerpiece of their general plan update. And you can see here that youth not only provided beautiful artwork that was included throughout the plan, they also directly informed policies in their health element, which has a particular focus on making the city a healthier place for young people. I want to share another creative example, which comes from Los Angeles, where they had a huge group of organizations and residents that participated in a series of workshops designed to create a vision for safer streets. And there, planner James Rojas invited people of all ages and backgrounds to take a more playful approach to city planning, as you can see on this table, by using toys and crafts. James is an advocate for the power of imagination and play to connect people to each other and to their community's future. And here you can see people were asked to design an ideal street for the next 50 years. This vision is put into policy through Los Angeles' Great Streets Strategy, which is a plan with the ambitious goal of reducing traffic deaths to zero within 10 years. This is part of a growing movement called Vision Zero, which some of you may be aware of, that really seeks to create safer streets for everyone by eliminating traffic fatalities. People, but especially children and older adults, often report that getting hit by a vehicle is one of the greatest barriers, or fear of getting hit by a vehicle is one of their greatest barriers to walking and bicycling. So improving safety has the potential to yield significant health benefits, not just in preventing injuries, but also in encouraging more active transportation. And Los Angeles' plan really reinforces that connection between health, equity, and transportation policy, stating almost half of the traffic fatalities on our streets today are people walking or biking, and Los Angeles has double the national average rate of children and older adults who die while walking. Each of these deaths represents a tremendous loss for families, neighborhoods, and our city. The design of our streets can change these trends in a powerful and permanent way, partnering engineering with enforcement, education, and outreach. And I think that's just such a powerful statement of how community vision, a focus on health, can really translate into strong policy statements. So our building block number 3 is make a plan. And hey, for those of us who are on the line today who are planners, this one should come naturally. So this block here shows cities and counties that had drafted or adopted general plans that addressed health in 2011. And it's a little out of date. I would love to update this research. But I show it because I think it provides a quick snapshot of how California communities of all shapes and sizes are using their general plan as policy tools to improve community health. There's many cities that have done this, and I could spend probably all day talking about great examples of healthy general plans, but one city that was on the leading edge of this approach was Richmond, which adopted a community health and wellness element in their city's general plan in 2012. And just to reinforce this idea that health is not just the purview of doctors and hospitals, take a look at this implementation table that has a list of priority actions from their health element. And as you can see here, we have a whole list of agencies who may not have certainly not always thought of themselves as health promoters like engineering or public works. And you can see they're listed right here as key implementation partners. Collaboration between planning, public health, and other agency partners really took off in Richmond with the creation of their health element. And the city was so committed to that new approach that they actually ended up adopting a health and all policy strategy to guide all of their public policy going forward. So moving on, this brings us to building block number 4, which is to invest in change. And investing in change really means thinking creatively and looking for ways to save or repurpose or combine or even attract new resources. So here you see this guy. His name's Chip Johnson, and he's mayor of Hernando, Mississippi, which is a small city. It's about 15,000 population, where skyrocketing obesity rates were threatening his city's quality of life and their bottom line. And for Mayor Johnson, he's really come out as a leader on this issue that a healthy community is not just a feel-good thing. It impacts economic development and fiscal health. In Hernando, by adopting policies that encouraged healthier eating and active living, and they really went the whole gamut here. They did things like opening schoolyards for community use through joint use agreements. They were creating farmers markets, serving healthier food in city cafeterias. They were building new parks and passing a complete streets policy. Hernando was able to shave 15% off their health insurance costs, which is not insignificant at a time when we sort of assume that healthcare costs are always going to be on the rise. Another way to think about how healthy policies affect the bottom line is to look at job creation. And here's just one example of how investing in healthier communities can be a win-win. So active transportation projects actually create more jobs than traditional road projects. And not only that, they provide a bigger health return on investment in injury reduction, improved mental and respiratory health, and in reduced chronic disease, all by making it safer to walk or bike. Investment can also mean training staff on new approaches. So in Richmond, the city is training staff on why health equity matters and how different government projects can impact health equity. That way, across the entire city, staff understand how their unique or individual roles can contribute to a more equitable city overall. It also might mean funding staff positions that provide cross-agency functions, like a planner embedded in a health department or a public health professional working for a planning department. And these kinds of roles are not quite yet widespread, but they make a big difference. And Riverside County is one example of a local government that has funded a planner within their health department. But let's just be honest. Lack of resources is often the first excuse people give for not trying a new approach. And that's why I just love this quote from Michael Osier, who reminds us that creative people always find a way, saying, nobody has money. We have people and resources, not money. But we can help do a health fair. We can bring those resources, and then we would work our way up. You have to have a big view and realize that while there's no money to do this, there are a lot of groups that are doing similar work. If you all work together, you can actually make it all work. And as communities that have started working together are in a better position to respond to unique and new funding opportunities that arise, I wanted to share just one example. So through funding from the Centers for Disease Control and Prevention, the American Planning Association has just released an RFP to fund collaborative projects between local APA and APHA affiliates that are working on physical activity and healthy eating. So if any of you listening today represent California chapters, this looks like a great opportunity that I hope you'll pursue. And last but not least, building block number 5, which is tracking progress. This, too, is an opportunity for Planning Health to collaborate in measuring whether or not visions and goals in our plans are actually achieved over time. And tracking progress is a really important step for health and health policies because it really can help hold agencies accountable. So one of the most common ways that communities do this is to release annual reports or reports on a regular basis. And these reports usually detail the status of health and health inequities, where progress is being made, and if there are any recommended changes to policies and practices. And here are just 2 examples from Chicago and Seattle where city agencies report on how they've contributed to specific benchmarks and made progress towards shared goals. I also wanted to share this example from Riverside, which is a similar type of report. Evaluating the effectiveness of policies and practices is really a powerful way to communicate success and create buy-in for continued work. And it's really hard to know if you're going in the right direction if you don't keep calibrating your position on the map. Okay, so that's it. These 5 building blocks are really the foundation, I think, of a strong health and health policies approach. But really they're the foundation of approach that I think will be the way that we have to do government going forward. We have to be more collaborative, we have to share resources, we have to be lean and nimble, and we have to do a better job engaging our community constituencies. And I think these building blocks provide a wonderful framework for linking planning and public health. So now that you're ready to go out and start talking to your local health department or planning department, I just wanted to let you know about a couple of great resources. Be sure to check out this roadmap to healthier general plans. It's a really nice short overview guide that outlines roles for planners, public health staff, community organizations, and local funders at each step of a plan's development process. And you may also be interested in our toolkits on healthy planning or participating in the planning process. And we have a huge library of model general plan policies, including ones on healthy housing, urban agriculture, complete streets, safe routes to school, and many more. And all of these resources are available free of charge on our website. And as always, I work with attorneys, so I have to tell you that Change Lab Solutions is a nonpartisan organization that does not provide legal advice. And I'd love to take any questions or comments that you have now, and please don't hesitate to contact me if you'd like to follow up on any of the examples or resources that I've shared.
That's great, Heather. Thank you. We've got a couple questions coming in, and hopefully we get a couple more. I think I think the overview is just a huge, it just shows how many places are working on this from very different perspectives. So that's fantastic. I'm actually going to take the screen back, but wanted to see, Dick, if you had any specific thoughts. Dick, are you there? Might not be there. Well, in the meantime, I think one of the questions came in. As we see health and environmental justice concerns are often brought to light at a local level. As you mentioned, there's a lot of great examples from the county level. What are some ideas of how you've been able to integrate those in terms of the time frame and scope of different projects?
There's a lot packed into that question. I do want to emphasize that while public health departments in California for the most part sit within county government agencies, there are tons of examples of collaboration between cities and counties. So that Southgate example that I gave you, that's a city within LA County. The example that I gave you in Arvin, where a public health department person was helping with engagement there, Arvin is a city within Kern County. Same for Richmond and many others. So communities are even figuring out how to bridge this jurisdictional gap, which I think is a real one, and it's one that just takes a little bit of, I think, creativity and relationship building to make work. So that's kind of one thing. But then the second part of that question, Elizabeth, was that really about kind of how different players fit in at different parts of the process?
Yeah, I think it's about how you start to bridge the different time frame and the issues, and yeah, I think the different.
Yeah, well, I will just say something brief on that, which is that most of the places that I think have been successful at doing this kind of work are ready to jump in sort of no matter what's happening at the local level. So not every city in California is going through a general plan update, you know, as we speak, which is obviously a huge opportunity to integrate health and planning, but it's not the only way. So there might be specific plans that are happening in a neighborhood. There might be a transit-oriented development plan that's happening in a neighborhood. There might be a corridor plan. There might be a particular, you know, affordable housing project or something that's happening. Successful communities are entrepreneurial, and they work with the opportunity in front of them, knowing that this is a long-term project. I mean, building these kinds of relationships it's not about an overnight way of transforming government, and it's certainly not about a single project. It's really about using these as stepping stones towards a more collaborative and comprehensive approach to integrating health and planning. So whatever's happening right now in your community, there's probably something that you can figure out about how to better link these two practices.
Great.
Elizabeth, can you hear me?
Dick? Yes, yeah, we can hear you.
A couple quick comments. One, Heather, thank you. That was a terrific presentation, and I try and keep track of this, but there's so much more going on. I want to emphasize, one, your point about the power of cross assignments. Even if you don't have the money, getting someone over to the other department and infecting, whether it's transportation or planning or one of the other agencies, with the health point of view, but also our learning their limitations and lexicon and challenges. It's so important, and it doesn't take a huge amount of resources. The other quick one is metrics are really important. You're exactly right, but narrative is too. And if there are ways of capturing these stories in vignettes, YouTube videos, etc., that has an awful lot of traction as well.
Great point.
Definitely. I think one of the other questions, and I think this goes for both of you, and I think it actually touches on, you know, your presentation, Dick, about, you know, some of the existing built environment, and Heather kind of looking at the long-range planning. One of the questions that's come in is, what are things local governments can do in existing built environment? So, you know, kind of that whole process around retrofitting different areas. And what are your thoughts on that?
You know, can I jump in, Heather? But I'm face-to-face with this as the lead for the Be Well, Built Environment Well in the UCLA campus, and we're trying to make it a bike-friendly campus. We've tripled the number of bike parking spaces and finally put in green striping for routes around the campus, put in 25-mile-an-hour speed limits. No one knew what the speed limit was. And we're trying to use this nidus, this nest, to then go outward for a bike route over to Culver City, to Santa Monica Hospital, and to other locations. So it's really creating a node, and every step of the way people are saying, no, I don't want it, no, it costs too much, no, bad people will come into my neighborhood. And it is a block-by-block struggle. It isn't, and you just have to keep at it.
Yeah, just to build on that point, I mean, I think infill is going to be the name of the game for the future in California. We can't develop the way that we have for the last 50 and 70 years for a variety of reasons. Money, resources, the environment, shifting demographics and shifting demand, market demand for housing types, aging populations, all kinds of reasons why we have a mandate to focus on infill as the way we plan our communities. And I think infill is both about, you know, finding ways to redevelop and revitalize neighborhoods through new buildings, new projects, but it's also or renovating existing buildings. It's also about the kinds of things that we don't necessarily always think about as being able to transform, but that are simple. And I really do want to emphasize this idea that paint on a street is something that can make a huge difference in terms of safety for bicyclists and pedestrians. It doesn't involve widening the roadway, and it doesn't involve new development per se, but it's a way of retrofitting an existing community to better serve our needs. I think we're going to have a lot of opportunity to be thinking about how can we upgrade buildings to make them healthier, how can we make sure we're supporting affordable housing going forward, how can we use our streets and our public spaces so they maximize benefits. This is not a greenfield story to me. This is a story about transforming what we have.
And it looks like we have about 2 minutes left, so I was going to say if you have a closing comment, and we still have a bunch of fantastic questions, a couple on food insecurity and what are the best ways to obtain data for health impact analysis. Some of it will actually be sharing resources on the LinkedIn invitation that we'll be sending out. And I just wanted to see if our speakers had some closing words.
I'm going to go first. I'm very optimistic. I'm seeing the best and brightest students from both public health, planning, and other groups more and more wanting to be involved. I'm seeing students coming over from the business school, the law school, and other areas also wanting to engage it. They're tired of 20th century thinking where everything's locked off into little separate silos and boxes.
Boy, that was almost exactly what I was going to say. I'm also optimistic. I think it's hard to be a planner and not be optimistic. We all come to this profession thinking that there's a possibility for human agency and human practice to make change and to make a better place for ourselves and for our children and our future. And I also am excited about the fact that I think we're really going to see the gains that we've made in treating professionals as specializations that go really deep in one area and hang out by themselves to working together. It's where innovation comes from, and innovation can touch the public sector just like everywhere else.
Fantastic. And on that, I'm actually going to let everybody know that there are questions. So some of the questions we'll actually try to answer through resources and continue this conversation. Thank you guys so much for joining. I'm actually going to go through the questions with our speakers and try to get some answers out to you all through the LinkedIn group that we share. It's been fantastic having you both. Thank you both so much for your time. And definitely for everyone who's on the line, stay tuned for the next sessions. And I encourage you to make new connections. Thanks so much.
Thank you.
Thanks.